Moving on to our next topic, I would like to invite the chairperson, Dr. Jayashankar CA, who is the professor of Department of Medicine, Vaidehi Institute of Medical Sciences, Bangalore, and Dr. K. Prem Kumar, Associate Professor of Medicine, Government Medical College, Anandpur.
Good afternoon, everyone. First of all, I would like to thank Dr. Srinivasmurthy sir for giving me an opportunity to chair a session in this CME. It's my duty to introduce the speaker, Dr. Ajith Kumar. Sir is a consultant physician and diabetologist at Dr. Ajith's Total Diabetic Care Center, Tirunelveli, Kerala. Sir will be talking on lipid lowering in clinical practice in PWD. Over to you, sir.
Thank you, Jaypersons. Very good afternoon. First of all, I would like to thank Srinivasmurthy sir. He is always an inspiring person for me. I think he is a very really motivating person, and in a Sunday post-noon session, I think it's a good crowd. My job today is to just tell that lipid lowering in clinical practice in people with diabetes, we all know it is one of the, it's not a commodity, but it is one of the commonest association of our metabolic dysfunction in our body whenever who has got a diabetes. So I'll be spreading, my menu will be briefly mentioning about the lipid metabolism, the importance of lipid management because it has got a strong association with atherosclerotic vascular disease, the available guidelines, what we mean by the lifestyle changes or the pharmacological interventions. So diabetes is associated with a cluster of interrelated plasma lipid and lipoprotein abnormalities. We grossly label them as a dyslipidemia. Even the type 2 diabetes or the pre-diabetes or a metabolic syndrome patients can be attributable to the clustering of several CVD risk factors like hypertension, maybe hyperglycemia, the obesity, and prothrombotic tendency. We all know obesity itself, a systemic inflammation produces because of the presence of adipose tissue, and all these factors contributes to major risk factor like the cardiovascular outcome in diabetes patients. This is the prevalence worldwide. It says about diabetes patients, about 70%, roughly about 70% of people will have a coexistence of dyslipidemia. There are various permutation combinations there. We can see that, is it working? Oh, sorry. Okay. So you can see from the side the proportion of the people with the diabetes and dyslipidemia, they may have hypertension or they may not have hypertension, and how it leads to the atherosclerosis. So this is a prevalence in India, about 80 million people, the number may be going every second, and 90% of Indian diabetes are dyslipidemia. That is a problem. And 9 out of 10 diabetes patients suffer from dyslipidemia. I think if we take account of people who are sitting here, I pray that it should be less than 30%, but we know more than 70% of us are having some kind of a dyslipidemia. These are the atherosclerotic risk factors in Indian diabetic dyslipidemia. 25% there will be in smoker, and a diabetic smoker will have a lot of problem with the dyslipidemia, and they will have a high chance of getting a peripheral occlusive arterial disease, and that will end up in amputation and later complications. And 27% will have a hypertension, and about 63% will have a dyslipidemia. This is a diagnostic parameter. We say that desirable cholesterol is less than 200. You all aware about that number. Triglyceride should be less than 150. HDL is 60, but it is very difficult. I don't see how many of us have 60 HDL. LDL should be 60 to 130, and you can see the cholesterol HDL ratio also. And the high risk means the main factor we have to address is LDL cholesterol, and if we can increase the HDL, then it will be good. So the strongest evidence to explain the increased atherosclerotic, as I said, the coexistence of diabetes and the meds, and the dyslipidemia and diabetes has got a peculiar feature, especially in Indian population. You will be having low LDL, high triglyceride, and low HDL. Whether it is male or female, the pattern is somewhere same. And whenever there is a small dense, the number of small dense LDL particle increases, I think it increases the risk of the atherosclerotic cardiovascular diseases. The small LDL particles are considered to be more atherogenic than the larger or buoyant the LDL particles, because they are the oxidation and the glycation is more in that, and they will get more deposited in the arterial wall, and they will be pro-inflammatory, and they have and they will increase the atherogenic properties. As I said, the triglyceride will be increased hepatic VLDL production, insulin resistance, because when we go back to our old biochemistry class, we know that there will, from the intestine, the enterohepatic circulation comes to the liver is the house of synthesis of cholesterol. We know 2-acetyl-CoA molecule combines and it forms into the malonyl-CoA, and from there the cholesterol comes. Cholesterol itself is an integral part of lot of our cellular functions, but if we, the rate limiting step is the HMG-CoA reductase level. And certain newer drugs are there because the citrate comes and from the TCA cycle, the citrate comes and it binds with the acetyl-CoA, and from there the step starts with the malonyl-CoA and the IPP and the GPP. Finally, it comes into cholesterol. So if we can block that pathway at any point, whether at the beginning or in the mid level with the reducing the HMG-CoA reductase inhibition, we will be able to achieve the target. So all these factors, if high triglyceride, high LDL and low HDL is considered as an atherogenic dyslipidemia, and all these factors will simultaneously contribute for the insulin resistance is already there. So there will be increased lipolysis, increased free fatty acids, and these factors will promote the inflammation. And there will be oxidation stress in the form of increased TRP, increased fibrinogen, and increased lipid peroxidation. So this slide you can see there are two things we are given. That is what I said. If in any individual, same individual with the same status, two individuals the same status of LDL, if the small density lipoprotein molecules are more in that particular individual, I think they will have an elevated ApoB and they will be having more risk of developing atherogenic sclerosis. Other factors involved in pathogenesis is hyperglycemia. It itself leads to endothelial dysfunction due to reduced nitric oxide. We all know that oxidative stress is there because of the advanced glycation products with the RAGE interactions. There will be a lot of superoxide overproduction will be there. Inflammation, it's a part of metabolic syndrome and type 2 diabetes, which is marked by the high presence of CRP and serum amyloid. This is the atherogenic dyslipidemia. I already told you. And wherever the increased concentration of small dense LDL is increased, you will have a high risk. So these are the current various guidelines, the ESC, BAS and ACC guidelines. The screening and assessment and management of lipid disorders in patients with diabetes are among the most important steps. You can screen for the measurement of lipids can be performed in individuals who fast, or the latest recommendation says that even if the patient is or the individual is not fasting, you can take a lipid profile sample and you can do the lipid analysis. These are the risk categories of LDL cholesterol targets. You have very high risk, moderate based upon the atherosclerotic vascular disease. By either you can do a CT imaging, that is what people are saying nowadays, guidelines are saying. Diabetes with target organ or a long duration of diabetes, more than 20 years associated with a very high risk. There the LDL target should be as low as possible. In a general population with reasonably controlled diabetes, the ideal target should be LDL less than 100. There is a debate between neurologists and the other physicians about the target of LDL, but these are our diabetic agencies says that it is better to keep LDL as low as possible to prevent the long-term atherosclerotic cardiovascular disease. These are the target by the ADA. ADA guidelines says LDL should be less than 70 in high-risk individuals, less than 55 in very high-risk individuals, and you can go for a moderate or a high-intensity statins recommended for all diabetes over 40 years of age. Maybe as a primary prevention factor, you can start up statins in anybody who is having any diabetes is more than 40 years. We usually follow ADA guidelines in our day-to-day practice. There is ESC guideline is also there and ACC guidelines also there. This is the Lipid Association of India, if diabetes mellitus without any atherosclerotic cardiovascular disease and with cardiovascular disease, without, if there is no target organ damage, if they are in the high risk group, at the time of the diagnosis, you send lipid profile including ApoB and lipoprotein. If it is possible, a patient is affordable, please do an apoprotein B and a lipoprotein A, and you can start a LDL lowering agent as per the percent reduction of LDL, and you please look if the triglyceride is more than 500, especially some guidelines is more than 700, you have to tackle the triglyceride. The aim of tackling triglyceride is only to prevent the pancreatitis. And the right side, the diabetes with atherosclerotic, if no target organ damage, extreme risk group, the category, the target, as I said, LDL should be less than 50. So how you can implement the current guidelines? And especially whenever you are treating a dyslipidemia in a diabetes patient, you have to target for the LDL reduction. You have other molecules like ezetimibe, bempedoic acid is there, the PCSK9 inhibitors which is coming up, There are two that monoclonal antibodies are there, and siRNA molecule that is inclisiran. I think that will be reaching the market soon. I don't know whether it is started available in Bangalore. I think it will be launched in the next month, I think including Bangalore and Trivandrum. So these are the lipid lowering therapies. That I said, the major part of the cholesterol comes from the intestine, from our diet. Then it goes into through the intrahepatic circulation, the liver, whether the synthesis starts. Various levels are there, starting from the citrate to acetyl-CoA. There the enzyme, if you inhibit, it will be the bempedoic acid. If you come down little down, acetyl-CoA to cholesterol, before after the HMG-CoA going into become the malonyl-CoA, the HMG-CoA reductase inhibitor is there. If you can inhibit that can be achieved by the statins, and these PCSK9 inhibitor, that is basically the inclisiran, is again acting, and these are the two potent drugs. The PCSK9 and the statins are the most potent drugs which can reduce the LDL. And you have fibrates, you have niacin, which is used when nowadays people are not using because of a lot of side effects. Ezetimibe is there. But our main target should be the LDL cholesterol. And statins, we all know it produces the competitive inhibitors or HMG-CoA reductase. Statin reduces the risk of ASCVD in patients with diabetes by an average of 20%. It's a big number, 20% for every 39 milligram per deciliter decrease in LDL cholesterol. And is it justified if we go for a LDL cholesterol, focus on LDL cholesterol? Because since we all know that LDL cholesterol is the primary target in lipid lowering therapy, the NCEP, ATP3 or AD, all guidelines says that LDL lowering therapy is a vital component to reduce the cardiovascular risk, and what is the way we are focusing on LDL. And this is a statin overview. There is a high intensity statin is there, moderate intensity is low intensity is there. High intensity, it will reduce LDL for more than 50%. Moderate intensity will reduce 30 to 49%. Low intensity, about less than 30%. So high intensity dose is atorvastatin 40 to 80, rosuvastatin 20 to 40. So it says if you are giving 10 milligram of atorvastatin, the corresponding dosage of rosuvastatin is 5 milligram, half of that. And we don't use too much of pitavastatin or simvastatin in Indian population. Moderate intensity, that is what we usually resort, atorvastatin 10 to 20, rosuvastatin 5 to 10, simvas 20 to 40. And low intensity is simvastatin 10, and usually they are not commenting about the atorvastatin or rosuvastatin in that. And metabolism, out of all the statins, almost all are microsomal inducers except one, that is pravastatin. So I don't think we are using too much of pravastatin in Indian population. And there is always a controversy says that when to administer statin, people say that it should be in the night time because the HMG-CoA reductase inhibitor activity is more in the night time. But if you are giving rosuvastatin and atorvastatin, because rosuvastatin is considered as the longest half-life of about 19 hours, atorvastatin is followed by rosuvastatin for about 14 hours. So even if you give it in the morning or afternoon or in the evening, it doesn't affect. So because of long half-life, especially rosuvastatin. And meals. Again, the absorption of meals may affect all the statins except the pravastatin. And the most potent statin out of all the statins it is pitavastatin followed by rosuvastatin. The least effective are simvastatin. Means least potent. So these are the intensity of lipid lowering. If you moderate intensity statin, you will get 30% reduction. High intensity statin, 50% reduction. And PCSK9, I think this will take over the market in another 1 or 2 years time, but only problem is cost. I think this will reduce about 60%. Is intensive statin therapy safe? It is a very debatable topic, but whenever it is administered at recommended doses, there is more efficacious statins have a risk of rhabdomyolysis. So you have to monitor your patient regularly. Usually, if you combine statin with either a fibrate or a niacin, the complication like rhabdomyolysis may increase. So this is the recommendation. The NICE guideline says that you have to do a baseline lipid profile. You check an AST and ALT. Keep always watch on patient and ask them, report them, tell them to report back to you if they have some constant muscle pain or aches. 3 months you can again repeat lipid profile and AST and ALT. And it says that if you notice an increase from the basal upper limit, say for upper limit is 40, if it goes up to 120, then you have to be little careful and you have to taper the dose. or you can stop and switch over to another statin. If it is from 40 to 50 or 40 to 60, it goes up, you don't get panic and you can just wait. So this is a classification of statin-related muscle toxicity. I won't go into detail. Just for the information I am sharing, it is better thing is if you are suspecting myopathy or myositis, please do a CKMB and you just look. If myalgia or intolerance is there, there are 5 classifications there. And it is a spectrum of myalgia to severe myopathy. If it is a grade not preclude statin therapy, consider reducing the statin dose. If 1 to 3, manage according to the pathway. And when SRM4 is suspected without any evidence of impaired renal function, discontinue statin therapy immediately and refer the patient for an outpatient management. I have not seen too much of toxicity with the statin till date. And statin-based approaches to manage muscle symptom, a person-centered approach, you should be there. Therapy starts with the lower dose of statin, then you titrate, that will be good. And you can go for a de-challenge and re-challenge. Give something, then stop it, then again reintroduce or change the type of the molecule you are giving and watch for any symptoms develop. And since the rosuvastatin and atorvastatin has got a longer half-life, permitting their use on a non-daily regime if you want. It's always on a person to person. Coming to ezetimibe, it is a highly selective inhibitor of intestinal absorption of cholesterol, reduced concentration of cholesterol in portal blood and hence upregulation of LDL. Whenever the liver is looking for the cholesterol which comes from our dietary source, if it is not getting, the liver will itself increase the LDL receptor numbers and it will try to absorb all the cholesterol which comes from the intrahepatic circulation and our plasma cholesterol will be controlled. It has got statin also has got a pleiotropic effect because plaque stabilization is important. Ezetimibe also has got a pleiotropic benefit. It improves the platelet aggregation, reduction in the oxidative stress, which additionally aid in CVD protection. This is upfront combination therapy. So the International Lipid Expert Panel says that to achieve the target, initial healthy in patients with diabetes could include 2 steps, would focus on LDL cholesterol. You can use a combination of statin or ezetimibe as initial therapy with the goal of achieving more than 50% of LDL cholesterol if you think he is a high-risk individual. There are a lot of pooled analysis of clinical trials are there. You can refer due to lack of time and not going into the details. This is a rationale of combination because the statin reduces LDL, C reduction, antioxidant effect. Ezetimibe also synergizes the action and this both the ezetimibe plus statin will be a good combination. And the ezetimibe has got a better control on the postprandial hyperlipemia also. This is the iROSET trial, not going into the details. It is a double-blind multi-center trial and this study had shown that LDL lowering efficacy of this combination is superior to rosuvastatin monotherapy in the 5 or 10 or 20 milligram dosage. And the LDL target is achieved more in a group with the combination therapy and the safety and efficacy was also well documented. So bile acid sequestrants is not that potent, but you can give bile acid sequestrants and demonstrated to improve the glycemic control also. But problem is they have a lot of GI side effects. This is PCSK9 molecule and I don't have any experience of using this molecule. This will be reaching the market soon. Inclisiran is a small interfering RNA molecule and the only advantage is you have to give two times in a year and it is an injectable molecule. Better tolerance, only problem is the cost. I think the cost will be somewhere around 90 to 95,000 for a single injection and almost all the insurance companies has accepted it and in the last budget also finance minister was included this molecule under some reduction or something like that. So this is they say it's a 300 milligram molecule. This is sorry for the market name, but I was searching the net, I got this information. In combination with the statin or statin with the other lipid lowering therapies, you can, if you are not achieving the target, you can go for this. It is an excellent drug as per the literature. It says it will reduce the LDL by about more than 50%. And one good thing is there is no too much of dose adjustment is needed. The up to the moderate the liver hepatic dysfunction you can give. And up to the severe, even the severe renal impairment, there is no need for too much of dose reduction. The contraindication, there is no contraindication, only hypersensitivity reaction or the local site reaction are mentioned. And hemodialysis patient, you should not be used for at least 72 hours after the inclisiran dose. The goals of treatment, as I said, these are the guidelines which says LDL should be less than 70, non-HDL cholesterol should be less than 100. If the American Association of Clinical Endocrinology says that extreme risk, it should be less than 55. A very high risk, it should be less than 70, and ApoB should be less than 80. If possible, do ApoB. Bempedoic acid is again, it inhibits from the start of the molecule. The citrate combines with acetyl-CoA, the inhibitor of ATP citrate lysis, and the clear study has shown that it is a very excellent molecule. I think most of you may be using it, and it tends to improve the glycemic control also. Fibrates, again, it is PPR gamma agonist. You have to be very careful when you are combining with the statins. And phenobarbital, both as monotherapy and in combination with the simvastatin, it is good. And fibrates could be used for the prevention of, it is one drug which can be helpful in preventing the retinopathy also. Omega-3 fatty acid, you need high dosage, but it's not, the RCTs are not promoting. These are the research molecule, ApoC3 and ANGPL3 inhibitors. I'll take 20 seconds. And these are the molecule. I don't have any experience. I only read from the literature. I don't know whether it is available in India or not. And emenaquinab is again the antibody against the ANGPL3, and it shows that more than 70% reduction of plasma triglyceride levels. CETP inhibitors are also there. Lifestyle modification, you have DASH diet, Mediterranean diet. One thing you have to be very careful, lifestyle modification, the total calorie, the fat consumption should be less than 25% of total calorie consumption, and in that saturated fat should be less than 7% of total calories in a day, and total cholesterol should be less than 200. If you can achieve that, LDL cholesterol reduction should be more than 20%. So the take-home message is lipid management very essential. Lifestyle changes plays a crucial role, but you have statin and newer therapies are waiting on the wings. Thanks once again. Thanks for the opportunity for Srinivasa Murthy sir, the team highlights. I think I just overshoot 20 seconds. Thank you all. Have a great day. Jai Hind.
Thank you, Dr. Ajith Kumar sir, for your wonderful talk. Since we are running short of time, only one question is allowed from audience. Sir,
thank you, sir.
From my side, I have a question, sir. Sir, what is your recommendation regarding lipid-lowering therapy in diabetics with normal lipid profile, sir?
See, it says even if it is normal and he has got a high risk, if he is especially he is a smoker or family history of cardiovascular disease, after the age of 40 years of age, you can, I think, put him on a statin. That is a low intensity statin. That is what it says.
Thank you, sir.
Thank you.
Thank you so much. Thank you so much, sir, for the speaker and the chairperson. We request the chairpersons to hand over the memento to the speaker.